Welcome LQB482. In today's practical class, we're going on a field trip to investigate a patient with a suspected case of gallstones. Our patient is experiencing symptoms such as severe and sudden biliary colic, pyrexia, shivering, and severe nausea, typical symptoms of gallstones. However, it is also very common to be asymptomatic. There are several imaging modalities that can confirm the diagnosis of this suspected pathology. Let's orientate ourselves within the body.
The gallbladder is located inferior to the liver in the upper right quadrant of the abdomen. As part of the biliary system, the gallbladder stores bile produced by the liver, which is an integral fluid for digestion. Cholecystolithiasis, also known as gallstones, occurs when bile in the gallbladder accumulates to form a small, hardened deposit. There are 3 types of gallstones. However, the most common type is a mixed composition stone. Gallstones more commonly occur in women. Factors which can also increase this risk are obesity, diabetes, oral contraceptives, and hormone therapy.
Computed tomography and magnetic resonance imaging are 2 different imaging modalities useful for visualizing soft tissue structures.
Both modalities produce a 2D image with no superimposition or magnification artifact, increasing the accuracy of diagnosis. CT is less expensive, yields faster results, and is more accessible than MRI. Additionally, a greater spectrum of absorbance allows tissues of all densities to be visualized. This aids in viewing suspected pathologies and surrounding structures. MRI is a safer option in comparison to CT, as it does not involve ionizing radiation. However, it's unable to be used by patients with metal implants due to the magnets employed by the machine.
After comparing and contrasting the imaging capabilities and other aspects of both MRI and CT, it can be concluded that CT is the most effective imaging modality to visualize gallstones.
In this axial CT scan of the abdomen, the gallbladder appears here as a semi-radiopaque pear-shaped organ. It's bordered posteriorly by the right kidney and anterolaterally by the liver, both semi-radiopaque. Within the gallbladder, we can observe lentil-sized radiopaque structures which have an irregular circular shape. These gallstones appear radiopaque due to its calcified composition observed as a high-density structure. Visualization of these gallstones become more obvious when compared to that of a healthy individual. Radiographically, the surrounding organs and structures of the abdomen appear the same in both individuals. In a healthy individual, the gallbladder is a completely semi-radiopaque structure, unlike that of the patient, whose gallbladder is obstructed by radiopaque gallstones.
Prior to imaging, symptoms accompanying gallstones may be mistaken as signs of other biliary disorders. After observing the CT scan, a pathology such as gallbladder polyps may be misdiagnosed as gallstones, as they are of similar size and shape within the gallbladder. However, while the gallstones have a radiopaque appearance, the polyps appear semi-radiopaque. This allows a clear differentiation between the 2 pathologies. When gallstones are not clearly identifiable on a CT scan, there can be other abnormalities present that suggest a diagnosis of gallstones. As bile flows from the gallbladder to the small intestine, a gallstone can cause ulceration through the gallbladder wall, creating an abnormal connection between the gallbladder and the duodenum, known as cholecystocolonic fistula. This can be seen here by a semi-radiopaque irregular-shaped protrusion. Another key identifying feature is pneumobilia, which can occur from an accumulation of gas within the biliary tree. Appearing here as a radiolucent tree structure located laterally to the gallbladder, pneumobilia corroborates the diagnosis of dysfunction in the biliary system as a result of gallstones.